Dear colleagues, this presentation is prepared for clinical key for electrical stimulation in physiotherapy and rehabilitation projects. The project partners are Pamukkale University, University of Craiova, Hatay Mustafa Kemal University, Başkent University, Süleyman Demirel University, Şilay State University of Applied Sciences, Burdur Mehmet Akif Ersoy University, and National Physiotherapy Associations. I am Özlem Yürük from Başkent University. The subject is electrical stimulation for neurotmesis. Neurotmesis is a complete transection of a peripheral nerve. Etiologies of traumatic peripheral nerve injury include high-velocity trauma, lacerations, bone fractures, penetrating injury, crash, traction, ischemia, and less common mechanisms such as thermal, electric shock, and radiation. Sunderland's 50-degree injury corresponds to the definition of neurotmesis in Seddon's classification and represents the highest degree of the nerve injury with a complete nerve defect. In neurotmesis, the entire nerve, including the endoneurium, perineurium, and epineurium, is completely severed. After neurotmesis occurs, many cell signals and neurotrophic factors are involved, as seen in Wallerian degeneration. Within 30 minutes after injury, intracellular processes that promote repair and regeneration have already been activated. The Schwann cells play an indispensable role in promoting regeneration by producing neurotrophic factors and increasing their synthesis of surface cell adhesion molecules. Schwann cells adaptively respond to axonal interruption, switching from highly myelinating state to a dedifferentiated state. Schwann cells engulf debris and form a regeneration path for axon growth. Schwann cells also secrete a group of neurotrophic factors, including nerve growth factors, and brain-derived neurotrophic factor, glial cell line-derived neurotrophic factor to encourage neuron survival and axon elongation. Although the physiological recovery starts, surgical repair is required after neurotmesis. If surgery is not performed time, degeneration of motor neurons and loss of axon regeneration can occur, leading to loss of function. Complete loss of function, motor functions, loss of sensory functions, autonomical loss, and cortex plasticity occur after neurotmesis. Recovery is more difficult as there is a complete motor and sensory loss. Muscle denervation continues for a long time. Axons may be misdirected due to disruption of the continuity of the endoneurial tubule. Neuromas frequently occur and can be a source of pain. Target muscle atrophy becomes irreversible, often 12 to 18 months of denervation, which limits the functional outcome of the repair. Axon regrowth is 1 millimeter in a day from the site of injury or surgical repair. When the regenerative distance exceeds 20 inches, even when the axons successfully reach their target, they are non-functional because the innervated muscle fibers undergo fibrofatty degeneration at 20 to 24 months. Physical examination of the involved extremity and muscles innervated point toward a specific nerve involved. Before planning a physiotherapy and rehabilitation program, the patient evaluation is essential. The sensory distribution of the nerve is tested. There is a complete anesthesia of the sensory distribution of the nerve. All involved muscles show flaccid paralysis. Eliciting a Tinel sign is useful in following patients with peripheral nerve injuries to determine the regeneration of axons across the defect. Physiotherapists perform electrodiagnostic tests and evaluate muscle strength, range of motion, dermatome, anthropometric properties, posture, viscoelastic properties of the muscles, pain, and autonomic functions in patients with peripheral nerve injury. The Faraday cake stability test should be routinely performed for follow-up of the recovery process. The technology is also helpful in screening nerve injuries for clinicians. Differentiation from neuropraxia or axonotmesis from neurotmesis is done by observing nerve continuity and the demonstration of proximal and distal nerve stumps. It also provides information of presence and location of neuromass, the length of any gap and anatomical continuity after nerve grafting procedures. MRI, ultrasound, EMG are the most useful screening techniques to differentiate between the axonotmesis and neurotmesis. The aim of the electrical stimulation in neurotmesis are keep the muscle active while waiting for regeneration, delay atrophy and fibrosis, stimulate reinnervation, and decrease pain. The effects of electrical stimulation on neurotmesis should be considered in terms of the innervated muscle, nerve regeneration, and pain management. Electrical muscle stimulation, brief intraoperative electrical stimulation, magnetic field therapy, and TINS, transcutaneous electrical nerve stimulation, can be used for neurotmesis. The effects of electrical stimulation on the innervated muscles are it upregulates intramuscular levels of glial cell-derived neurotrophic factors, RNA. This increase in trophic factor diffused into the distal nerve stump provided the beneficial effects of axon regeneration at the growth cone, facilitated nerve regeneration. The daily electrical stimulation also provides muscles that have greater number of reinnervated motor units with smaller average motor unit size. On the other hand, the neural activity reduced motor unit enlargement. Electrical stimulation didn't improve functional outcomes. The gene expression of neural cell adhesive molecules protein was altered by electrical stimulation. And also electrical stimulation reduces acetylcholine sensitivity. And the effects of electrical stimulation on nerve regeneration. Electrical stimulation has been demonstrated to augment nerve regeneration after peripheral nerve injury and repair in both animal models and humans. Experimental studies have demonstrated electrical stimulation to be a promising adjunctive therapy to enhance axonal regeneration and functional recovery following decompression and repair using grafts. Electrical stimulation acts through a retrograde action potentials to increase cyclic adenosine monophosphate levels in the soma, which drives the increased expression of brain-derived neurotrophic factors. Although the exact mechanism is not completely clear, electrical stimulation promotes axonal outgrowth and survival. Extensive animal studies have reported the ability of brief intraoperative electrical stimulation to enhance functional regeneration after peripheral nerve injury. The 1 hour 20 Hz electrical stimulation of the nerve after nerve repair enhances the early expression of brain-derived neurotrophic factors and pro-regenerative associated genes and facilitate the sensory and motor axons grow faster across the suture site after transection of femoral nerve in rats. In addition to recent studies supporting the encouraging the effects of electrical stimulation on nerve regeneration, some studies showed that increased neural activity on sprouting remains unclear and controversial. The electrical stimulation of facial nerve didn't improve the functional outcome nor reduce aberrant regeneration of facial nerve reconstruction in rats. The only positive effect of this treatment on nerve was transient improvement in protraction velocity between 1 to 3 months after surgical reconstruction. Pulsed electromagnetic fields have beneficial effects on nerve regeneration. The biological basis of magnetic stimulation mainly relies on protein synthesis, ion channel regulation, and growth factor secretion. However, little research has examined the nerve conduction characteristics of regenerating peripheral nerves under pulsed electromagnetic field on sciatic nerve regeneration in short and long term after crushing damage. 24 female Wistar albino rats are divided into 3 groups: sham, sciatic nerve injury, and electrical pulsed electromagnetic field stimulation. The stimulation group was exposed to pulsed stimulation low frequency for 40 days. The results indicated that electrical stimulation, pulsed electromagnetic field stimulation, was not effective in long term. However, it might be useful in short term, and more studies are needed to precisely evaluate and optimize the intensity and duration of the application in humans. Peripheral nerve injury can be associated with a combination of nociceptive, neuropathic, and complex regional pain syndromes. The incidence of the neuropathic pain is high. Neuropathic pain results from damage to somatosensory system, and its progression toward chronicity depends upon disruptions affecting both the peripheral and central nervous systems. Managing these painful conditions is complex. Transcutaneous electrical nerve stimulation can regulate neuromodulation based on Manzek and Wall's gate control theory of pain. It has a very low rate of adverse effects and complications. Although an initial success with TENS could be observed in up to 60 and 65% of patients, such benefits often wane over time, with only 20 and 30% of patients reporting any meaningful analgesic effect after 1 or 2 months of treatment. Here is the summarized advantages and disadvantages of electrical stimulation on reinnervation. The advantages of electrical stimulation are: it reduces venostasis and edema, increases muscle-derived neurotrophic factors, delays atrophy and fibrosis, keeps the muscle active while waiting for regeneration, reduces pain, enhances sensory inputs, and maintains relationship between the cortex and peripheral organs, reduces scar formation. And the disadvantages are it causes trauma to the innervated muscle because of overstimulation, decreases production of neural cell adhesive molecules and acetylcholine sensitivity, delays or inhibits collateral sprouting and reinnervation, mimics the voluntary contractions. However, there are not same the physiological mechanism as exercise. No added benefit for trophic condition. The number of contractions per day is insufficient, and it only stimulated the superficial fibers. Different electrical stimulation techniques are used for neurotmesis. Intraoperative brief electrical stimulation on the injured side, electrical muscle stimulation, pulsed electromagnetic field stimulation, and TENS. Intraoperative brief electrical stimulation is a recent technique that has been shown to be effective in studies. Biphasic current with 20 Hz and 100 microseconds for 1 hour with implanted electrodes is used. Although the technique seems effective for regeneration, it is impractical for physiotherapists because electrical stimulation is used only after nerve repair, and it is an invasive technique. Here is the electrical muscle stimulation protocol for neurotmesis. As mentioned before, if the muscle is deinnervated, it is stimulated via sarcolemma. This is called electrical muscle stimulation. The electrical muscle stimulation is a traditional technique for peripheral nerve injury. It can be used for completely and partially deinnervated muscles. Because of the physiological changes of completely denervated muscles, only modified galvanic current can elicit a contraction response. The pulse duration should be above 100 milliseconds, and the pulse interval should be 2 times of pulse duration. If the reinnervation begins, the muscles can respond to the Faradic current. Faradic stability tests should be routinely performed for reinnervation. The Faradic current is alternating biphasic current with a short pulse duration. Therefore, it cannot be effective in complete deinnervation. The muscle doesn't give a contraction response for Faradic stability test. The galvanic current should be used for electrical stimulation. In partial deinnervation, also the Faradic current can also be used, but in neurotmesis, galvanic currents should be chosen for stimulation. The applications should not be too long due to the low oxidative energy mechanism and should be done 3 days a week for maximum 8 weeks. It is recommended that the current amplitude be as high as is tolerable and capable of stimulating tetanic contraction of the target muscle. The atrophied and deinnervated muscle are vulnerable to trauma. Excessive electrical stimulation can cause trauma. So higher current amplitude may be needed for contractions. However, higher amplitudes also cause trauma. The 200 muscle contractions per day are sufficient to prevent muscle fiber atrophy. However, to prevent fatigue, 90 contractions of each muscle should be performed as 3 sets of 30, 30, 30, or 2 sets of 45 contractions. The treatment sessions are planned 3 or 5 times in a week for approximately 8 weeks. The electrode size and type depend on the size of the muscle to be stimulated and the intensity of the contraction to be elicited. Small or pen electrodes can be used to localize the stimulation for small muscles. Larger electrodes are needed to stimulate larger muscles or muscle groups. One electrode may be placed over the most excitable part of the muscle. The second electrode was placed at the convenient location near the muscle being treated. Due to the elongated sarcomere length of the denervated muscle, the length of the muscle should be shortened while performing electrical stimulation. Applications should not be too long due to the low oxidative energy mechanism and should be done 3 days a week for maximum 8 weeks. Physiotherapists should avoid fatigue when using electrical stimulation. The electrical stimulation should be started after the nerve reinnervation begins and should be terminated after the active movement begins. The antagonist should not contract simultaneously. And pulsed electrical magnetic field therapy for neurotmesis. Studies have investigated different magnetic field properties and in the intensities. Various magnetic nanoparticle encapsulating stockings based on superparamagnetism, magnetically functionalized nanofibers and their relevant mechanisms and clinical applications. A suitable applications of magnetic field or magnetic biomaterials can shorten the regeneration time of peripheral nerves and promote the release of growth factors. The magnetic field therapy parameter can be set at 0 to 20 millitesla and a frequency of 50 to 100 Hertz. And transcutaneous electrical nerve stimulation for neurotmesis. Neuromas frequently occur and can be a source of pain in neurotmesis. The pain is typically neuropathic, characterized by burning and dysesthesias. TENS is a method of electrical stimulation that aims to provide symptomatic pain relief by exciting sensory nerves and stimulating either the pain gate mechanism or opioid system. The different methods of applying TENS relate to these different physiological mechanisms. Conventional TENS can be used for neurotmesis, or maybe acupuncture type TENS on painful side can be used for pain in peripheral nerve injuries. And here is the clinical evidence of electrical stimulation. Although the clinicians and researchers have tested the usefulness of electrical stimulation applications for enhancement of peripheral nerve regeneration for more than a century, the efficacy of such treatment for facial paralysis remains questionable. In a recent small but long prospective observational study, Arnott et al. Included 3 patients with early onset of electrical muscle stimulation of zygomatic muscle as home training after facial nerve lesion during schwannoma surgery with spontaneous regeneration or after facial nerve repair. Selective zygomatic muscle response in the absence of discomfort was reproducibly obtained. The electrical stimulation parameters were 50 millisecond pulse duration and 7 Hz frequency of triangular single pulses. The required amplitude was remarkably lower with 5 milliamperes. In these patients in early after the onset of the facial nerve lesion compared with the other patients with long-term denervation. The authors found that The electrical stimulation parameter was not causing discomfort and unwanted unspecific reactions of other ipsilateral or contralateral facial muscles. Appropriate electrical stimulation doesn't hinder the regeneration of facial nerve. It maintains muscle function between the onset of the lesion and spontaneous reinnervation or surgically induced reinnervation of target muscles. It may also reduce synkinetic reinnervation, although data are still rare to sparse to allow the general conclusions. And trauma to the spinal roots of the brachial plexus and cauda equina typically results in a lower motor neuron syndrome, with a denervation of peripheral target sensory impairments from dorsal root injury and pain. Historically, nerve root injuries have been associated with an overall poor clinical outcome, as a successful repair strategy would also require axonal regeneration within both the central nervous system tissue of the spinal cord and the peripheral nervous system. Kern et al. Investigated the effects of electrical stimulation in a patient with long-standing quadriceps femoris muscle denervation. Stimulation started 18 months after injury. The author stimulated the quadriceps femoris muscle with biphasic rectangular current. The treatment was done for 15 minutes per day, 5 days per week. Biopsies revealed evidence from growth and regeneration of myofibers. The results suggest that electrical muscle stimulation may offer a route to the future development of mobility aids in patients with lower motor neuron lesions. And as conclusions, compared with axonotmesis, the reinnervation is not completely successful in neurotmesis. Therefore, the efficacy of electrical stimulation in prolonging the period before irreversible muscle atrophy and increasing the capacity for reinnervation remains unanswered. Electrical muscle stimulation, intraoperative brief electrical stimulation, TINS, and magnetic field stimulation can be used for neurotmesis. Clinical evidence suggests that 1 hour 20 Hz electrical stimulation applied intraoperatively following repair can improve patient recovery. However, it is an invasive technique and it is impractical. The other technique is electrical muscle stimulation. There are experimental and clinical studies on electrical muscle stimulation in the literature. Although some studies have shown the harmful effects, recent studies have supported electrical muscle stimulation. And more studies are needed to evaluate and optimize the intensity and duration of the electromagnetic field therapy and TINS applications in humans. Different studies show both positive and negative effects of electrical stimulation. Nevertheless, electrical stimulation has been shown to have beneficial effects in human subjects and thus a worthwhile approach to maintaining muscle mass and force. And thank you for your attention.